Hello, and thank you for the invitation to the GI Endoscopy Author Interview Series. My name is Sharara, and I'm Professor of Medicine in the Division of Gastroenterology at the American University Beirut Medical Center in Lebanon. I am pleased to present our research titled General Anesthesia and Deep Hypnotic State in Propofol-based Conscious Sedation for Endoscopy. Now, endoscopy is an important diagnostic and therapeutic method for many GI diseases. However, patients feel hesitant about undergoing the procedure due to anxiety, fear, embarrassment, and importantly, discomfort. Now, sedation can help ease these concerns, improve patient cooperation, and enhance the quality of the procedure. Therefore, there is an increased use of propofol-based sedation among endoscopists. The goal of this sedation is to achieve conscious sedation where patients remain responsive to verbal and tactile stimuli. However, there is a risk of patients slipping into deeper sedation, such as deep sedation or general anesthesia, which can lead to more adverse events and to a longer recovery period. Consequently, this may affect patient safety during and after the procedure, and monitoring the depth of sedation can be therefore an important aspect to ensure a quick recovery. Currently, there is limited evidence regarding the precise depth and duration of sedation achieved in clinical practice. Our study aimed to observe and to gather sedation depth data during GI endoscopy procedures when patients are receiving monitored anesthesia care administered by an anesthesiologist. The enrolled patients were part of a previously prospective cohort study called the RECOVER trial, published also in iGIE. In brief, outpatients aged between 18 and 75 years and scheduled for diagnostic bidirectional endoscopy with anesthesia-administered sedation were enrolled according to pre-specified inclusion and exclusion criteria. Evaluation of the depth of sedation was achieved using the bispectral index. The bispectral index, or BIS for abbreviation, is a non-invasive tool that uses EEG or electroencephalographic monitoring to provide anesthesiologists with a numerical indication of a patient's depth of sedation and the effects of anesthesia. Now, the BIS score ranges from 0 to 100 and corresponds to the depth of sedation. A BIS score below 60 indicates general anesthesia with a low probability of consciousness, while a score below 40 indicates a deep hypnotic state. Now, in the study design, after achieving a BIS score between 70 and 80 after a standardized induction regimen, the endoscopist initiated the procedure. Heart rate, blood pressure, pulse oximetry, and BIS readings were recorded at the beginning of sedation and every 5 minutes during the endoscopy. If patients experienced hypoventilation, as indicated by capnography, oxygen desaturation despite supplemental oxygen, or rapid and sustained drops in the BIS score below 50 to 60, the infusion of propofol was either reduced or temporarily stopped until recovery on the BIS monitor. The anesthesia team administered propofol at a rate of 100 to 150 microgram per kilo per minute, following an initial bolus of 10 to 50 milligrams as determined by the anesthesiologist. Additionally, patients received intravenous doses of 50 microgram of fentanyl and 2 milligram of midazolam. So this was a standardized regimen that was used in all patients. From the initial group of 120 patients enrolled in the original study, the randomized controlled study on bidirectional endoscopy, 95 patients had complete BIS recordings, and these constitute the current study population. The average duration of the procedure was 23.8 plus minus 5.9 minutes. And what was important in the study is that remarkably, 88% of patients experienced periods with a BIS score below 60 and 12.6% had scores below 40. On average, patients spent 9.1 minutes under general anesthesia and 3 minutes in a deep hypnotic state, representing roughly 40% and 12 to 13% of the total sedation time, respectively. Figure 1 illustrates the dips in recovery as recorded on the BIS monitoring from 2 selected patients, showing drop in the BIS to below 60 and below 40 with recovery according to the flow of the study and holding of the sedation regimen. We identified on univariate analysis that significant alcohol use was a predictor for dips in BIS scores below 40, with 17% of those who experienced less than 40 dips in the BIS being heavy alcohol users compared to only 2.4% of those who did not experience similar dips. Younger patients were more likely to experience BIS scores below 60, and on multivariate analysis for a BIS score of less than 40 or the deep hypnotic state, we could not identify any significant predictor. Table 3 shows the adverse events reported in patients with or without considerable dips in BIS score. There was no difference in the BIS less than 60 category, but as can be seen on the right column, patients with BIS scores below 40 had a higher incidence of post-operative dizziness assessed both at discharge and at 24 hours later, with the dizziness occurring in up to 25% of patients having a BIS drop less than 40 versus 7.2% in those who did not have such a drop with a significant p-value. So our study findings highlight that a considerable proportion of patients experienced deeper levels of sedation than intended during endoscopy with propofol-based sedation. This is an important observation because we also had the opportunity to intervene when the dips in the BIS were seen clinically, and it could be without such monitoring that patients could even go into a deeper level of sedation that may not be recognized. These findings have a significant implication for patient safety, as deeper sedation levels are associated with increased risk of hemodynamic instability, delayed recovery, and cognitive effects. Further studies are needed to identify additional predictors of deep sedation and to develop improved methods for monitoring and managing sedation depth. Our study does underscore the importance of continuous and accurate sedation monitoring to ensure patient safety and optimize recovery times in endoscopy. Thank you.